Hi again. The first time that I ever made a video talking about work at all, the intensive care unit, was after 5 weeks of just exhausting physically, mentally, emotionally assignments. I was really frustrated and I went on this long rant, and somehow people related to that and actually asked that I make more videos talking about work. And it all felt really weird because I still feel that I have so much to know, so much to learn. Constantly, I feel like behind, like I want to know more. And that, why didn't I know this? Why don't I know that? I'm like, wow, there's so much left for me to know. So I felt weird making a video of tips or advice or anything like that. And then I finally decided that I have been surrounded by people who were completely willing to educate me. And then some people that were messaging me didn't feel that they had those resources. So I'm pretty much giving you the things that I've learned or I've stumbled through with the resources that I've had for people that don't feel as fortunate. So to explain myself a little bit, I graduated with my BSN in 2015. I've been an ICU nurse for over 2 years now. I have my CCRN, and most importantly, I have been learning from highly intelligent people who have 10, 20, 30 years of experience, and I've tried to get as many educational opportunities as I could. So this video that I'm gonna make are the very, very basics of your first day walking into the ICU, what you should know. I'm not gonna try to break down the coagulation cascade. We're not gonna try to solve ARDS here. These are the very, very basic things you should know when you walk into the critical care unit your first day. This is also my personal information, so if your preceptor, your hospital, your unit does things differently, by all means, do what works best for you, your hospital, your unit. So number one, the most important lab values. When I do my first scan of lab values, my eyes automatically go to potassium, magnesium, and hemoglobin. Everything else I look through on my second scan, but my first scan, for the most part, regardless of what medical condition this patient has, potassium, hemoglobin, and magnesium are pretty important to every patient. In our hospital, it seems to be a potassium of 4, a magnesium of less than 2, and a hemoglobin less than 7. Deserves a do we need to replace this type of question. So if you see a potassium less than 4, do we need to replace this? You see a magnesium less than 2, do we need to replace this? You see a hemoglobin of 7, do we need to replace this? Those are good questions to ask. And if you are having ectopy, meaning frequent PVCs, premature ventricular contractions, frequent PACs, premature atrial contractions, if you're seeing the heart rhythm kind of do weird stuff, first question that's coming to your mind is, what is their mag and K? And if you don't know that, if you don't have a recent one, perfectly fine to put in an order. At our hospital, we have standing orders. Put in a mag and potassium stat and get their mag and K and see if it needs to be replaced. Number 2, heparin. If you walk in and your patient's on a heparin drip, the first question that should come into your mind is, when is their next PTT due? Then when you get a PTT result back on that patient, you should look at your heparin order set and see, do I need to make a titration? Do I need to go up and down on their heparin drip? So for example, patient's on a heparin drip. Oh, okay. When is their next PTT due? Oh, it's due at 10 a.m. Great. 10:15 a.m., PTT results come back. Review them, and then based off of your heparin order set, see if you need to titrate up or down on your heparin drip, or not titrate at all. This one seems pretty clear to all ICU nurses who have experience, but it's not clear to nurses who just come into ICU. Never ever turn off your drips. Don't let them be too long. Don't let them run dry. Don't ever turn them off unless you are absolutely certain it's only for a short amount of time and they're going to be able to handle that pause. So what are drips? What drips should I be worried about? Well, there's Levophed, epinephrine, vasopressin, dobutamine, dopamine, propofol, dexmedetomidine, amiodarone, heparin. You know what? If it's running continuously and it's not a fluid like lactated ringers or normal saline, if it's not a KVO, you should question whether it's okay to pause that at all. So when you're first starting out, it's perfectly fine to be like, is it okay if I pause this? Until you really become comfortable around drips. Swan-Ganz catheters. Yes, they're a dying line, but in our hospital we use them quite a bit. In other hospitals they do too. This is going to be a very short thing because, of course, this could be a long lesson. There's tons of people who lecture on these for a very, very long time. The basics of this that you need to know as a brand new nurse is make sure that they've been confirmed by x-ray that they're in the right spot. measure them as soon as you walk in and you assess your patient. Measure the Swan-Ganz catheter. Normal for right IJ is like 50 to 60, subclavian is similar to right IJ, 50 to 60, and femoral is like 70 to 80. Of course, patient body habitus makes a difference, but make sure that you measure them, mark it down, and then check at least every 4 hours, preferably more frequently, and make sure that they are staying in the same spot, that they're not getting pulled out, they're not getting pushed in. So that's really important. NG tubes and OG tubes. Similar to Swan-Ganz catheters, you want to make sure that they're in the right place. So measure them, mark it down, and make sure that they don't get pulled out or pushed in. Always confirm placement with x-ray. The whole air bolus thing, it's not really being practiced anymore. Research is showing that it's not appropriate, that you can't really tell if it's in a lung or in a stomach. It's very hard to do. So confirm it with x-ray. A-line. An arterial line, that red waveform that you'll see on the monitor, is a line that's placed into an artery that has a constant measurement of a blood pressure. It is supposed to be the most accurate blood pressure possible, and it's constantly measuring your blood pressures, right? Never ever try to push meds through an A line, okay? You will literally feel the line. It's hard, and it's not like the IV tubing. It's like pressure. It is hard, and it's in the artery. Never try to push meds through that. What you can do is you can draw blood off of it. So you can draw bloods for labs, for sugars, because you want to look at it, whatever. You can draw blood off of them, okay? And an arterial line, it'll show the systolic, diastolic, and a lot of times it's really important for the map. Now, what is a map? A map is a mean arterial pressure. The name kind of describes what it is. It is the mean pressure within the artery, right? So what's important about it? The number 65. 65 seems to be the gold standard for almost everyone, unless it's written in an order that they want it higher or lower, whatever. At 65, it's telling you that it's perfusing well north to south. So if this number goes below 65, you need to do something to fix that blood pressure. If it's transient, okay, but what I'm saying is if it's staying below 65, you need to do something to fix the blood pressure. Put on drips, fluid boluses, tell a scary story, whatever works, but get their blood pressure up. Of course, check with your orders and make sure that they're not accepting a number lower, but usually 65 is the really important number. Hourly expectations in the ICU. At the top of every hour, you should at least be checking urine output, blood pressure, heart rhythm, heart rate, respiratory rate, oxygen saturation, and any other critical care monitoring like intra-aortic balloon pumps or Swan-Ganz numbers. And every 4 hours, you should be assessing the patient's pain and temperature. There's something else that is kind of fresh in my mind that is important to keep an eye on, is your patient's level of consciousness constantly. So that's what I have as far as first day in the ICU. If there's anything that I'm missing or anything that I said that you feel is incorrect, please correct me. I'm all about learning. I would love to know your opinions, your thoughts, how your hospital does things. I hope this helps someone. You know what I mean? I would have loved to have had this advice my first day going into the ICU. I ended up getting this advice and these lessons from my preceptors, from my mentors, from the people, my coworkers. But it would have been great to know this my first day walking into the ICU. So I hope that this helps somebody that is either going into the ICU soon or is already in there and feels themselves kind of struggling. Best of luck to all of you. Thank you for all that you do. It's a big, big family, and it's a roller coaster of a job, but it's totally worth it.